Thank you for joining us for this Seizure Smart Childcare Personnel Training. This training is being provided by the Epilepsy Foundation of Minnesota, a local nonprofit organization that serves Minnesota and Eastern North Dakota. The Epilepsy Foundation of Minnesota, or EFMN, is an affiliate of the National Epilepsy Foundation. My name is Amy Haugen, and I'm the Senior Regional Manager at EFMN. Tonight's presentation is 60 minutes in length. Please remember to jot down any questions you may have, and at the end of this presentation, we will provide contact information for myself, as well as contact information for our information services staff and webpage for you to get those questions answered. Our objectives are to define epilepsy and seizures, identify the 4 leading types of seizures, and learn the appropriate responses for those seizure types, increase your knowledge of the available treatment options that are out there for seizures and epilepsy, and give you information about caring for children with epilepsy and seizures. We'll dive in with what is epilepsy and defining epilepsy and seizures. Epilepsy is a neurological condition characterized by unprovoked recurrent seizures. 3 key terms in this definition are neurological, unprovoked, and recurrent. Neurological, meaning a medical condition diagnosed by a healthcare provider that impacts the brain and the neurological system, Unprovoked, meaning not caused by another medical condition or medical event. To give an example of a provoked seizure situation, you might have a child who has very high fevers that has a seizure, or an individual who has diabetes may have a seizure related to their blood sugar. These 2 examples are provoked seizures that would not fall into the epilepsy category. Unprovoked seizures and reoccurrence of seizures are key in the diagnosis of epilepsy. Reoccurrent meaning more than 1. There are specific epilepsy syndromes where 1 seizure will be enough for an epilepsy diagnosis, but those are more rare. And oftentimes those occur because that specific diagnosis is known to have epilepsy as a component, so that when an individual has 1 seizure and they have this medical condition, they may be diagnosed with epilepsy as well. We know that epilepsy is one term for this medical condition. We also know that other individuals who are living with epilepsy may choose to call it a seizure disorder or a seizure condition. It is an individual choice for that person with the medical health condition, and we know that there are reasons for using each of these different names. At the Epilepsy Foundation of Minnesota, we tend to use the word epilepsy as it is the historical term, and it is also the term that we use in most of our searches for information from reliable references and web pages. Some key facts about epilepsy that are driven out of some of what were known to be some of the myths. Epilepsy is not contagious. It's not viral. One child cannot pass it to another, nor can an adult pass it to another. It is a neurological physical condition that's occurring in the brain that is not able to be passed between people. We also know that epilepsy is not classified as a mental health condition or a mental illness. It is classified in the neurological sense under neurological conditions. Mental health conditions and mental illness conditions are also occurring in the brain, but the classifications are very different, and the way that they are diagnosed is very different. One thing to note, however, about epilepsy is that 50 to 60% of individuals who are diagnosed with epilepsy will at some point in their epilepsy journey also be diagnosed with a mental health condition. The most common ones being depression and anxiety. And there's many reasons for that, including the fact that maybe there is a perceived or real impact on their life that the seizures are having, and they aren't able to work, or they're not able to drive, or things of that nature. It could also be because they take medications that cause side effects that are mood changing side effects. Or the third reason for that comorbidity or of mental health with epilepsy could be that the seizures are coming from the part of their brain that is responsible for emotional control or mood control. And if your brain is misfiring in that area, having seizures in that area, it is likely, there's a higher likelihood that you may also have some mental health symptoms as well. Epilepsy exists on a spectrum, and the word spectrum is used quite widely in the medical world right now. And in the epilepsy world, what spectrum means is the impact of seizures on an individual's life, along with the level of seizure control that they have. So to give you an example, we might have two clients that we work with, both diagnosed as infants, both adults now, living with epilepsy. One might have one seizure type, take one medication, have seizure control for almost 20 years, work, drive, even go to school. And the impact on her life of having epilepsy is right now is remembering to take her medication every day. She would be on the low end of impact. On the other end of the spectrum, a similar aged woman has multiple seizure types, takes multiple medications, has undergone several brain surgeries, device implants. She is not able to work or drive because she has daily seizures. She even has a personal care attendant who is with her most days so that they are there in case she should have a seizure. She has a family, she has children, but in her case, the impact of the epilepsy and seizures is much higher because she doesn't have that seizure control and because she is not able to do some of the things that other adults might be able to do, like drive and work. So that is kind of the spectrum example in the world of epilepsy. We also know that people can die from having a seizure, but it is pretty rare. Some of the reasons that we know of for an individual dying from having a seizure are related to a prolonged seizure that is not witnessed, and a person perhaps is by themselves and they have a prolonged seizure that impacts their oxygen levels, their heart rate, things like that. Those would be called status situations. We also know that oftentimes accidents can occur when a seizure happens, whether it's an automobile accident or a fall with a head injury. Those types of things can lead to severe consequences and even death in some people. And then there's a third larger category called SUDEP, which is sudden unexpected death in epilepsy. And sudden unexpected death in epilepsy is one of those reasons where a person who has epilepsy dies, typically going into sleep, coming out of sleep, in the middle of sleep. And there are some key risk factors, but there isn't a known cause. We know that there are many, many researchers and doctors working on SUDEP research to determine what exactly is occurring at the time of death. What is the changes that are occurring that are proving to be fatal, so that we can do some things to be more proactive to reduce those risk factors. But it is considered rare because it is about 1 in 1,000 people with epilepsy. Epilepsy is super common. It's one of the more common neurological conditions. And when you look at the statistics here, we know that 1 in 26 people will develop epilepsy at some point in their lifetime. It does not discriminate in gender, age, race, culture, socioeconomic, meaning that it occurs in all of those. And we know that it's 1 in 26 people. So that is pretty common. What we know is even more common is the number of people who will have a single seizure event. That is 1 in 10 people. So if you think about your childcare center, your daycare setting, how many children you care for, maybe in a room, one of the center rooms, or maybe in your own home daycare. We know that 1 in 10 will have a seizure, and we know that 1 in 26 will have epilepsy. So that's super common. When you look at it as far as newly diagnosed, every year, 200,000 cases in the United States. And we know that the 2 highest incident rates occur in children and older adults. And really it's about brain development and brain deterioration for those two age groups. All age groups have occurrence, but children and older adults have the highest incident. The younger the child, the more likely they are to develop seizures. And that is because of the rapid brain development that occurs within those first 4 years of life. We know that it is very common, and when we look at other neurological conditions, migraine, stroke, and Alzheimer's occur more often, but epilepsy is fourth, and it occurs more often than many others combined, like cerebral palsy, cystic fibrosis, which is not neurological, multiple sclerosis, Parkinson's. You can put many of them together, and epilepsy occurs almost twice as often. It is the leading brain disorder in children, and we know that 1/3 of people who live with epilepsy are not just living with epilepsy, but they're living with uncontrolled seizures. You may hear the term refractory, intractable, but what it means is that their seizures are not controlled with their treatment option. So that's a good portion of the people with this diagnosis who don't have a treatment that's working. We know that adults with epilepsy are more likely to have 4 or more co-occurring conditions. Anxiety and depression are 2 that I mentioned before, but things like autism, ADHD, and one of the biggest pieces for adults is sleep disorders. Sleep can be a critical factor in seizure control. And so the fact that many people, in particular adults that live with epilepsy, also have a sleep condition can be one of those struggles to get control for both the sleep disorder and the seizures, knowing that they impact one another. Within the United States, there are certain populations that we know there are some disparities in the occurrence rate. Like I mentioned, it doesn't discriminate in that it occurs in all races, cultures, socioeconomic statuses, genders, and ages, but there are some disparities. We know that people with low economic status are 2 to 4 times more likely to develop seizures. Perhaps it has to do with their access to healthcare. Perhaps it has to do with their ability to take care of their health, things like that. But we also know that there are certain racial groups, African American and Hispanic to be specific, who account for a significant portion of those who have epilepsy, about 40% of people. If you looked at the percentages in the general population, African Americans are about 18 or 12.5% of our population in the United States. Hispanic Americans are about 18.7%. And so when you think of those 2 numbers, and then you see that 40% of people with epilepsy fall into these 2 groups, there's a disproportionate number that are African American or who identify as Hispanic. We also know that in childhood, epilepsy is about 1/3 of the children that live with epilepsy are in food insecure homes, compared to about 1 in 5 in the general population. And that 1 in 3 can be a result of a couple of different things. The cost of having a chronic health condition, the ability for the parents to work because they're taking care of a child with a chronic health condition, the cost of healthcare, the cost of medication, all of those things can impact the stability of the ability of the income for parents to provide and have a food secure home. And in those who are adults living with active epilepsy, the average, about 50% of them have an average family income of less than $25,000. Again, that number is about 17 to 20% in the general population. So if you have epilepsy, there's a higher percentage that are living with less than $25,000 a year. Again, for some of those reasons of maybe it is their ability to work full time because of a chronic health condition, the cost of healthcare, all of those things might be factors for them. We know there are several causes for epilepsy. So again, remembering we talked about epilepsy is a unprovoked recurrent seizure disorder, and there are many causes. And when you think of causes, the first thing to think about is brain structure. So a physical structure of a brain that looks normal is functioning by neurons communicating with one another for our bodies to function, whether it's how we talk, how we walk, our eating, our breathing, all of those things. If a person's brain structure is not normal, maybe there's been an injury, maybe there's a swelling, maybe there's a death of part of the brain through stroke, maybe they didn't develop correctly in utero, or they have a tumor or a lesion, or all of those things change the way the brain is able to communicate and can lead to seizures, which then can lead to that diagnosis. We do know that there are brain infections also encephalitis and meningitis are the two main infections that can lead to seizures. And we know that in brain infections, a person can start having seizures while that infection is active. The infection can be treated and cured, but the threshold for seizures is lowered for some people, and they may continue to have seizures for the rest of their life and therefore get that epilepsy diagnosis where they need to be under the care of a neurologist for treating those seizures. When you look at all of these causes, the big news is that about 60 to 70% of individuals don't know why they have epilepsy. So the reasons we know of account for 30 to 40% of the people, but the majority of people do not know why. And some of the reasons for that unknown, we know is that there's a lot of genetic research being done where they're trying to determine at the very granular DNA strand level if there are mutations or deletions that are causing seizures at the DNA level. We also know that technology isn't as individualized as it would need to be to come up with or to be able to detect all of the reasons for an individual person to be having seizures, because the brain is the most intricate organ. We also know that sometimes seizures occur years after the cause, which might be a head injury or things of that nature. So it might be that years have passed and the physician or healthcare provider isn't willing to put the two together as that is the causation. And so there's lots of work being done to work on bringing that 60 to 70% causation, unknown causation down. We're going to move over into talking now specifically about what a seizure is. So we said epilepsy is recurrent seizures. Well, what is that seizure? A seizure is a finite event. It's a medical event that occurs. And as you can see in this brain, there's multiple lobes of your brain that are responsible for different activities, different functions of your body. And when a seizure occurs, it begins and it ends, and it can be timed. And it's a brief, uncontrolled, unexpected misfiring in the brain. So it's like an electrical storm in the brain where the neurons are misfiring. And what happens then is outwardly different things occur depending on how much of the brain is involved, where in the brain it's occurring, and the intensity of the actual misfiring in the brain. So we know, like I mentioned earlier, that seizures themselves can occur with other conditions and other medical events such as high fevers or things like diabetes and heart conditions. So there are moments where there are just that 1 in 10 seizure that's occurring, and it's not related to epilepsy, so keep that in mind. But we also know that when those reoccurring seizures, there's lots of things that the doctors are looking at to determine what kind of seizure is occurring, and we'll talk about that in just a few moments. So I mentioned at the beginning that we're going to talk about the 4 leading types of seizures. We know that there are over 40 types, but 4 types right now that are the most commonly seen and responded to are the 4 we're going to talk about. And because this is a childcare training, we are going to actually add in 3 other types, because we know there are some specific seizure types that occur only in infant toddler ages. And so we're going to cover those with you as well, but we're going to start with the 4 most common types. And to give you a little bit of an overview of how is it determined, what goes into determining what kind of a seizure a person's having. The first thing that is looked at, whether it's through an EEG, which is measuring their electrical brainwave activity, or perhaps a scan, the doctors are looking at where in the brain is this happening? Where is the misfiring happening? Is it focal? Meaning, is there one spot in their brain that's seizing and they can pinpoint that spot and they know that's where it's originating? Or is it occurring across both hemispheres of their brain and all of their brain is involved, which would be called in a generalized situation? Or is it hard to tell? And do they have to do further testing to determine whether it's focal or generalized? Because sometimes they need to put the type into the unknown category until they've had the opportunity to do the advanced testing and really try to pinpoint where it's coming from. Once they determine where in the brain it's located, excuse me, they then will look at, is there a change in their awareness level? Are they able to talk, communicate, respond to you in a regular way? Or is there an altered sense of awareness? Or is there a loss of awareness where there's a loss of consciousness? And the final component they look at is, with all of those other things, are there other changes to their speech, to their behavior, to their movement, to what they're sensing? All of those things together equal out to helping them identify what type of seizure the person is having. A person can have one type of seizure, they can have multiple types of seizures. And so keep in mind as we go through these, some of them some people might have multiple kinds. And so I might talk about 2 or 3 that they actually have, whereas other people will only have one. The key in all of this is remembering that epilepsy is a very individualized condition. So the first focal type we'll talk about is called focal aware. This is one where there's no change in awareness. And so the person is able to talk and continue to communicate. In young children, when these occur, they might explain it as something they feel funny, or they smell something funny, or they taste something weird in their mouth. They might use those descriptive kind of words. And what occurs during this seizure is really the change in awareness. There's no change in the awareness, but what the sensation is something that is unusual and not occurring for anyone else, right? So they smell something, they taste something, they get really hot or cold, they get really nauseous. And it's a finite event, remember, so it starts suddenly and it stops suddenly, and they return to normal after the seizure. So really key in this one is emotional reassurance. And in a childcare setting, you're going to want to document whatever you're noticing. In young children, this one, they might not be able to tell you this is happening because they're not verbal yet. And so if this kind is occurring in a young child, you might look for little movements maybe that they have that seem to be rhythmic. Otherwise, it might be that this one happens along with another kind, and that's where they end up in a diagnosis of epilepsy. We have clients who have said things like, I feel super hot or super cold, or I get really, really scared, but it passes when the seizure is done because the misfiring has stopped. The second focal type we're going to talk about is called focal impaired aware. Now, this seizure type is one of the most common types of seizures, but oftentimes it is one of the most misunderstood. I'm going to show you a clip of one of these, but I want to explain a little bit of what happens during it and give you another example. So really there's a change in awareness. It's not lost, but there's an altering of it. So think of it as the person is able to hear you, see you, they have their senses about them, but they will not respond that at the higher level, in that they will not follow directions. They will not answer probably appropriately if they are verbal. And so what it will look like is all of a sudden they begin to have some purposeless movements, like picking at their clothes or wringing their hands or fluttering their eyes. Or maybe they stare off and they start to mumble, or maybe they stand up and start to wander. And it's really out of the blue, and within a couple of minutes it stops. And afterwards, after the seizure is over, many times the person is confused or concerned about what happened. To give you a great example of this one, when I was first working for the foundation, I met a family whose child had just started kindergarten, and he had been in preschool, he'd been in daycare. And when he started kindergarten, in the first few weeks of school, he kept coming home with below the line slips. It was a behavioral slip that said he was hitting, kicking, all these different things to his classmates. And so the parents were talking with him about it, and he kept denying it. And he kept saying, I didn't do that. I don't know what you're talking about. And he's 5. And so, he is adamant, and they are adamant that this is the truth because it's different teachers have witnessed it and things like that. And when they took him to the pediatrician for another, regular checkup, they brought up the behavioral thing because they were concerned that in the first couple of weeks of his first year of school, this was happening. And the pediatrician said, I believe he's having seizures. I'm going to refer you to neurology. Well, that hadn't even been in their mind because they did not know there were different types of seizures. Well, what was happening as they began to talk through it with school was that it was happening the same time of day. And it was when the bell rang coming in from recess. So many, many kids running towards the building to get in line, a lot of sensory overload. And the sensory overload would trigger him into a seizure. And then as he would stand there in the middle of his seizure, he'd get bumped by kids, and then he'd hit them or pull their hair or kick them, as that fight or flight response had kicked in for him, because he was really just protecting his body. That's the level of awareness he had. And so they were able to determine that that was occurring. And so what they were able to do is send him in a few minutes before the bell rang, and it took the trigger away. It also took away the fight or flight response and what was seen as behaviors, keeping in mind this whole time that this whole situation, he did not know what was happening because he was in the middle of a seizure with a changed level of awareness. So that's a great school example. I'm going to show you this video clip that's going to show you an adult that's having one of these types. So I'm going to walk you through what you heard there. So the man was walking in the mall, dropped his bags, kind of looked to one side, and began to shake and chew on his hand. As you saw the individuals around him, the security officer protesting if he could help him, no response. The other man came up and kind of put his hand in front of the security officer and said something about give him some space. And the security officer said, should I call EMS? Nope, I don't think so. Do you know this man? No, I don't. But he knew enough to know that it was a seizure. And so that's a really typical progression of this type of seizure, where the person is aware, they're conscious, their awareness has changed, they're not responding appropriately. And what could have really been what was really good about that situation is someone knew what it was. We also have many adults that have experiences that are not so positive, where people think that they're intoxicated or that they're high or that they're having a mental health crisis, and maybe law enforcement's called and they come to really realize, nope, this is a medical situation, not one of those behavioral things. So some things to keep in mind in the adult world. But there's some key ways to respond as well. Again, always knowing that individual diagnosis, individual experience equals individual response. But some of the key standard things are to stay calm, of course. Tracking time is important because we know that any seizure that goes longer than 5 minutes is considered what we call a status situation. And they will probably need either some additional medical intervention, or at the very least a rescue or an emergency medication. So tracking time is important. Again, that not restraining is really key in this type, because you want to avoid that fight or flight response. Remembering the individual is not going to remember any of their seizure activity or any of their response to those who are coming at them. You can gently guide them away from hazard, talking calmly to them to keep them safe and you safe. And then, of course, remaining until they have fully regained awareness, letting them know it's okay, they had a seizure, that you're there with them. And in your case, in the case of childcare, you're going to want to document per your documentation protocol. Moving into 2 generalized seizure types. We're going to first talk about absence seizures and then generalized tonic-clonic. An absence seizure, really, that word says a lot, absence of the person. It really is an alteration and a lapse of awareness where they are not going to be responding during the seizure at all. And it really looks like they're staring off, that they're daydreaming, that they have an attention issue. All of those kinds of things have been used as descriptors of what it looks like. But with this one, it's typically seconds in length, and they return right back to what they were doing. You'll see in the clip that I'm going to show you a young girl have a 5-second seizure, but you'll see that it starts, the seizure happens, and then she goes right back and says something to the person she's with. So keeping in mind that there might also be some things like eye fluttering or chewing of their lip, but really it's these brief moments of unawareness. And you might ask, well, why is this a very big deal if it's just a few seconds? With any seizure type, diagnosis and treatment is important because all of them can be treated. And then if they're not treated or diagnosed and treated, it can increase in frequency of that seizure type, or it could even change into more involved seizures as well. So diagnosis and treatment is key. But I'm going to show you this young lady that's having this type of seizure.
This girl has absence seizures, and you will see her have one while she's talking.
Because he can be as heavy as ever.
And there's a real blankness, a vacant look in the eye, and then all of a sudden they're right back with you and able to engage.
So that was really quick. As you noticed with her, she kind of looked off to the side, and when she came back, she said, "Oh, pardon." Very common. It was about a 5-second seizure. Keeping in mind with this one that the key in response is documentation, staying with them and reassuring them. And when we come to the end of the presentation, I'm going to give you some information about some of our templates and that you can use for observation records and action plans as well. So moving into the fourth type, which is a generalized type called generalized tonic-clonic, was known as a grand mal. Oftentimes we hear people say, "Oh, yep, I know what a seizure is. It's one of those grand mals where they get stiff and shake." And it is a seizure type, but it is not the most common type. And so, but it is one of the most impactful if you are responding to it because of what it looks like and how it progresses. So I am going to show you a clip of this one, but I want to talk through what you're going to see first. So the typical stages of this type of seizure is they might be, doing what they normally would be doing. And then all of a sudden there might be this sudden cry or moan that you hear from them, which is very common. And it's really that force of air up and out of their mouth. And as they cry or moan, they will typically lose consciousness. So if they're upright, they will fall down. If they're sitting, they might fall over. If they're a young baby and they cry out, it might just mean that they're laying there and they become stiff. And then they'll begin, that's called tonic, that stiffening rigidity. And then the clonic phase is when they begin to rhythmically shake or jerk or convulse. In that quick succession, some things can happen, like their breathing can become shallow or less frequent. Their lips or their fingertips or their cheeks can become discolored. Those are all really normal as long as you can see a breath pattern. Know that the oxygen they're taking in is being preserved to their heart. And so that discoloration you see is really normal. I'm going to show you this clip and then we'll talk through how to respond. But first, I'm going to show you the clip and then we'll talk a little bit through what you'll see here.
They affect the whole brain and the entire body. The tonic phase is the stiffening of the muscles. Then the jerking movements begin, the clonic activity that you see here. A tonic-clonic seizure rarely lasts more than a few minutes. A person having one isn't conscious and won't remember what happened. The skin may become pale. Breathing may seem shallow or labored. Sometimes a child may lose bladder or bowel control or vomit as the seizure ends. These seizures may look painful or even life-threatening.
So a couple things to note that go beyond the stiffening and the convulsing. You'll notice that there is vocalization, and that's really because the vocal cords become involved in the convulsive movement. And so you will hear sounds throughout the seizure typically. Their eyes typically will get really big, or they might roll towards the back of their head, but very rarely do they close. And so knowing that big wide-eyed look is really normal can help, because it doesn't mean they're looking at you sort of pleading for help. It's just the way that their eyes are involved during that unconscious event. A lot of drool, it can look like bubbles, it can look like foam. That's really the body's reaction to that kind of convulsing, and it just produces a lot of extra saliva. As you notice the seizure, as the seizure ended, the big thing that happens to indicate when it's ended is their body will become limp or just become sort of almost like a wet noodle. They release a big breath and they relax. And so that's how you know that the seizure has ended. Some steps to think about as far as how do you respond to this type of seizure. The first thing, like we've mentioned in other ones, is to time it. The minute you see it start, someone should start timing it until that sort of release of breath, relaxation, and that's when it's ended. It doesn't mean that the person will come right back to their normal activity or their normal consciousness state. It could take them 10 minutes, it could take them hours. Some people recover for a day or more, just depending on the impact individually on them. And because of what their brain and body has gone through, headache and fatigue and being sore are really common side effects of this type of seizure. You want to get them on their side. That's really about allowing that extra saliva to flow freely, getting their tongue to fall kind of to the side, to protect their airway, and also to prevent any choking should they vomit or have that all that extra saliva that is being produced. You also want to cushion their head because cushion it with something softer than the ground because headaches are one of the #1 side effects. It's good to get something under their head to provide a little extra cushion because their head will be involved in the convulsing as well. Removing anything that's in the way is key. Anything that's in the way, meaning it could be something they're wearing, such as glasses or a button-up shirt that needs to be unbuttoned at the top, or it could mean moving things in the environment, people, furniture, whatever you need to do to give them that space for their body to go through the seizure. You can move other people out of the way too, and just have one individual responding and taking the rest of that if it's a classroom or it's another group of children, to the side and get them doing something else. That is key as well. And then staying with them until they fully are aware, following their protocol, which we'll talk about in a little bit, and then staying with them and then alerting whoever you need to that the seizure has occurred from their emergency contact information. There are, like I mentioned, a few additional seizure types that we're going to talk through. These tend to be ones that occur in childhood. Oftentimes, they might occur starting in infancy or in toddler ages and then up into childhood. And they have a couple of additional things to look out for, if you will. The first one is a generalized one called a drop attack, atonic, or known as a drop attack. And really it's just exactly that word, the loss of muscle control. And so it is a sudden loss of muscle control where they will hit the ground. And it occurs very abruptly. And so oftentimes if you ever see a child or an adult who wears a helmet, soft-sided helmet, oftentimes they are diagnosed with these atonic or drop attack seizures because they have the highest head injury rate because of how sudden they are. The head will drop, collapse, and then or droop, or they'll hit the ground because they lose all muscle control. So oftentimes there's injuries that can occur with this one. The second type is called a myoclonic seizure, and that's also a generalized seizure type. And it's actually different from the atonic and different from the generalized tonic-clonic because it's brief. It's like muscle contractions where they almost like a twitching or a repetitive jerking. You might think, what is going on with them? You might think, oh, they're stumbling, they're clumsy, things like that, but it occurs generally on both sides of the body. And it's brief contraction of muscles, so it looks like jerking motions. So we're gonna show you a clip of an atonic one first.
Kit again.
Come on, lads, get a move on.
So I've got no kit.
It's all right. There'll be something in the cupboard you can use.
You can wear those red shorts again, Lee.
Andy?
Andy? Andy? Andy, you okay? Yeah?
So is he going to be okay?
Yeah, he's fine. Yeah. You two go and join Miss Macon in the gym.
So as you can see in this one, it literally was that sudden atonic loss of muscle control. So he was falling forward. He's also wearing a helmet. The teacher in this situation is great because he just responds very appropriately saying, hey, are you okay? And he has a couple of them in a row, these atonic seizures. And the other students are obviously concerned, hey, are you okay? And they ask the teacher, is he okay? And he says, yes. So really staying with them until they get through that seizure, and then, following if they have a protocol, if a parent or caregiver should be involved, or whether this is something where they can continue on with their day.
Uncontrollable.
I'm going to now show you what a myoclonic, this is an animation of a myoclonic one. And so we'll watch this one before we talk about response.
Uncontrollable jerks of a muscle or muscle group, which tend to last a few seconds. These can often be misinterpreted as a nervous tic since they tend to be nonviolent and the child does not lose consciousness. Usually, these tend to happen in the morning, but can also occur during sleep, which are then characterized as jolts.
So as you can see, there are the animation, it's those uncontrolled movements. Now this animation showed one side, then the other side. They can be the same sides as well, but common times, as they mentioned, are in the morning when they're coming out of sleep, or where they're going into sleep, as they're, for some reason, those are the most common types for this type of seizure to occur. So how do you respond to these two types? For an atonic seizure, it's really about lowering that child to safety. If they are continually doing that drop attack, if they have not, falling completely over, getting them to the lowest safe space, and staying with them until they get through the seizures. And again, if they're not injured, they most often can go back to whatever they were doing. However, if they do get injured or there's a suspected injury, calling 911 should occur. With the myoclonic seizures, there's less that can be done, really, because they're very brief. They're sudden and brief. And so with all types, again, proper documentation. With myoclonic and atonic too, just how many times was this happening? Because they can cluster and happen multiple times. Offering emotional support, they'll go through this cluster of them, and then perhaps, for the most part, they might be able to just continue on if there's no injury, or they might be a little more agitated with the myoclonic ones afterwards because they realize something's happening. But oftentimes, after a short period of time, they'll be able to continue on with their day like they would any other time. There is one third type we're going to talk through, and that's called the infantile spasm. It's a more severe form of infant stage seizures. And what happens is with this one is almost like a jackknife. It's sudden stiffening of the body, and they'll bend kind of towards each other. Their legs and their arms will come up towards each other. We'll watch a couple clips of this one. It's almost always in succession. So there's a few of them that will happen in a row. And again, that waking time is a huge time for these to occur. You can see on the right here, we have this infographic about what are you looking for with this type. You're looking for clusters of sudden repeated uncontrolled movements, sort of like head bobs or body crunching or jackknifing. If you're questioning, we know that taking a video with smartphones is a huge way that doctors are seeing some of what is happening in a home situation. Oftentimes actually doctors will say, yep, take that video and send it to me so I can see, because chances of them having an actual seizure during a standard visit might not happen. And that can lead to them diagnosing it or getting some more testing done to diagnose. And then really the key with this one is getting it under control, because the more this occurs, it's been shown to lead to or contribute to developmental delays, because they might occur more frequently and things like that. So I'm going to go ahead and show you this clip. Oh, sorry, one more thing to note. Oftentimes it looks like people will say, oh, they must just be fussy. They must have a belly ache. Their tummy must hurt. They must have gas, those kinds of things. But know that it occurs in infancy, and it typically ends in that preschool age. Oftentimes, if it's not controlled, they might develop developmental delays or developmental disabilities. Not sure of that reasoning, except that the impact on what's happening in their brain has been shown to actually have a higher risk for some of those developmental delays later on. So in those three clips, you saw three different examples, really subtle at times. And so oftentimes we'll hear people say, well, how do you determine that from like a startle response? As you noticed in that first clip, that the baby there was no reason for them to be startled. It was just this automatic sort of jackknife almost, or arms and legs coming together sort of situation. So it's subtle. It is not startling. It's not like they're reacting to something that's startling them. It just kind of occurs very subtly. Okay, we're going to talk a little bit about febrile seizures because they are so common in young children. So we've moved away from the epilepsy-related seizures, but we know that febrile seizures are oftentimes happen in young children, and it's a generalized tonic-clonic typically that is occurring because of a spike in body temperature. The key is a spike in body temperature, typically it's not a gradual rise in temperature, but it's like they spike a high fever, and oftentimes that leads to the misfiring in the brain, and then which leads to the generalized tonic-clonic seizure that occurs. You'll see things like they lose consciousness, they're jerking, twitching, they're struggling to breathe, or they're breathing a little bit more with a little bit more of a labored pattern, or they're rolling their eyes. Again, we know that febrile seizures can occur one time for a child, or they can occur every time that they spike that rapid spike in temperature, really between 6 months and 5 years. And typically after 5 years, it doesn't occur quite as often, or is actually more rare. So febrile seizures are real. They're not epilepsy related, but how you respond to them is really the same as that generalized tonic-clonic, making sure you get them on their side, you time the seizure, you're making sure that they're breathing, those kinds of things. And then oftentimes with febrile seizures, it's related to a health illness, and so they'll need to, per your protocol, go home, or the parents will need to be called to take them home because they have that high fever as well. If it does last more than 5 minutes, it is considered an emergency and should be, in any situation, whether it's epilepsy related or not, 911 should be called. And really, one of the things we always recommend is if they have that high of a fever that spikes and results in a seizure, they should see their doctor to determine the source of the fever, really, and like, what is it really that they seized because of that high spike, and what was that high spike in fever from? Is it viral? Is it something more serious? So that's the recommendation. We do have some seizure response protocols for on a bus. If you happen to have a bus situation or a van situation, really making sure to put them on their side. If it's a convulsive or it's non-convulsive, staying with them and observing. In school situations, we always say there's a protocol typically for school districts and their buses, like what is their standard protocol, pull to the side, radio back to the school, radio back to the bus barn, and then follow with their appropriate policy. So we know that really key is just getting them on their side, doing the same things that we would normally do, but it may mean having to pull over. Wheelchair, one of the things about wheelchair response is that most often children who are in wheelchairs, and adults, are in a wheelchair that's providing them support. And so we don't recommend you take them out of the wheelchair unless you can't protect their airway and protect them from harming themselves. Oftentimes, if it's able to be tilted, tilting it back a little bit, blocking it in and turning them on their side is what you'll need to do. When you start to take someone out of a wheelchair, oftentimes, it's hard to do when they're convulsing and stiff. And so sometimes it can lead to injury to them and yourself. So supporting their head, leaning them to one side, protecting that airway are key for wheelchair. Some things not to do. We know that there are things that might seem like, I think this is what I should be doing, but really we do not recommend is putting anything in their mouth. The old adage of putting in a spoon or a wooden stick or something to keep them from swallowing their tongue. We know that anything in their mouth can either lead to choking or to damage to their teeth and their jaw, so nothing in their mouth. Holding it down or restraining them will also lead to more muscle and potential, bone damage. And you could injure yourself as well. So don't want to hold them down, and you don't want to give them anything like food or drink or oral medications unless it's their emergency med. So you really want to preserve that airway and not, prevent any possibility of choking while they're having a seizure or right after the seizure as well. Calling 911, like immediately calling 911 as you look through these. They're pretty self-explanatory. I will say that if a seizure takes place in water, we know that even getting them out right away and on their side, 911 should be called because of the potential for getting water in their lungs. We talked about that 5 minutes or longer is called status, and that really should prompt a 911 call. Obviously, if they stop breathing or they're injured, if you don't know if they've ever had a seizure or you know that this is the first time one, we always recommend calling because we don't know why it's happening. Health conditions like diabetes, those fevers we talked about, also pregnant women. If they should have a generalized tonic-clonic seizure, those are all reasons to immediately call 911. And then, of course, if you don't feel like you can respond appropriately, like everything is going, you're doing exactly what you should be, and it doesn't in your gut feel right, always feel free to call. Just some general signs that a child might be having seizures, to kind of wrap all of what we just talked about into some of these symptoms and signs. Attention blackouts, if they suddenly fall a lot for no reason. Forgetfulness, there's any patterns to their behaviors or to their movements, or all of a sudden it's a very odd, unprovoked, repeated movement. If you have a child that seems to stare off and is saying, hey, what did you say? Or asking you to repeat yourself. Or you might even have a child that is unusually grouchy or has stomach pain. You know, if they have that with some other things that are indicative of seizure activity, that could be the response at the end of a seizure. Oftentimes we see children are more irritable afterwards because they're in pain or they're exhausted, those kinds of things. Key in all of that is looking for a pattern. So you look to see, write down what you're seeing, look for patterns. Isolated behaviors typically are not seizures, but if you see patterns of the same thing happening over and over, but if you see isolated behaviors, but maybe you see multiple different things that you know are seizure, potential seizure behaviors, like looking at them as a conglomerate, if they all add up, it could be a seizure. And of course, documenting is really key, and I'll show you that seizure observation record at the end. We know there are several treatment options, and we're going to quickly go through treatment options. Like I mentioned at the beginning, if you come up with questions at the end, you'll see my contact information as well as our information service page. We walk through these treatment options pretty quickly because they are really unique unto each person, and the decision for different types of treatment comes through. There's a progression typically that happens for providers as they're trying to help a person get their seizures under control. The number one treatment option is medication. There are other options: brain surgery, implant devices, diet, and medical cannabis. With medications, we know it's the primary way for seizures to become controlled, and that about 7 out of 10 or 70% of people with epilepsy will get control with medication. We also know that medications should not be stopped abruptly because of the impact it might have on the blood level or the med level in the blood. So really talking to doctors if you're changing doses or if you want to come off of medication is key. We also know that there's some different statistics. Once one seizure medicine is tried, about 47% of the people on that first medication will get control. If they don't get control, they'll try a second medication. And then in that second medication, about 13% get control. That's a second single medication. And then if they still don't get control at that third trial of a single medication, they end up at a 1 or less % of getting control. Oftentimes that's when you'll start seeing at that second medication, they add medications and do what they call polytherapy. So there's a couple of meds they're taking. Keeping in mind that side effects actually do occur with medications as well, and there's lots of different side effects. So looking as a whole at the person, what are the changes? A lot of times if you think of things like changes in behavior, changes in behavior or their personality, those kinds of things, or sudden like changes to their medical state, if you will. So if they get really lethargic, they gain or lose weight, they get really hyper, all of these things can be considered side effects, but many times a doctor will say, we need to give it a good trial, which is typically 4 to 6 weeks for your body to get adjusted or their body to get adjusted to the medication. If at the 4 to 6 week mark, they still are significant side effects, then they might say, yep, this probably is going to be too much and we need to wean down and try a new medication. There's lots of ways that you can track side effects, and we just bring this up because there's, with our phones and all of our technology these days, there's lots of different ways to track side effects, but we also know that you can track it on paper and pencil as well. If you're noticing differences in their personality or their behaviors or their way that they are handling different things, that's a key to write down and pass along to their parent or guardian. We know that at times there's also an emergency medication that might be given. And what an emergency medication is it is when a person is known to have seizures that are hard to stop, or that they might have a few in a row. Doctors may prescribe an emergency medication that can be given by a layperson, anyone. They'll be trained to give it, and they're easy to use. They work really quickly, and the goal is to stop the seizure, to shorten the seizure, or to shorten the recovery time. And they're not the same as a regular medication. Regular medication, daily medications are not emergency medications and won't help. If an extra dose won't help. But the as needed ones are typically in the benzodiazepine category, which is one that like suppresses brain activity. So it tries to bring it out of that hyper excited state that they're in. They are rectal, buccal, or nasal, meaning rectally given, in the cheek, or a spray in the nose. And so if you do have a child in your care that does have an emergency medication, the key is to make sure that you are trained in how to give that. If you have questions about how to give those medications, we are not medically trained, but we do have resources as far as videos and things we can send your way to show staff. We also know there are implanted devices that are out there. They are implanted. One is in the chest, two are actually in the brain, and they're really meant to record seizure activity, detect seizure activity, and to slow or stop seizure activity. So they're called the vagus nerve stimulator, the responsive neurostimulator, and the deep brain stimulator. And so you can see here, if you have a child that is the only one that is used in children is the VNS. If you have a child with the vagal nerve stimulator, we can provide more information on that specific treatment if you reach out. We also know that there are diets that are known to be effective. In particular, the ketogenic diet was actually a diet. The keto diet was started and developed by a doctor whose son had uncontrolled seizures. And in the epilepsy world, ketogenic diet is very, very controlled to the gram of what a person consumes. High fat, low protein, low carb. About 90% of the diet is in straight fat. And then carbs and protein are the other 10%. It limits their fluid. There's a fasting component, really strict. The thing that is known is that for some reason, the ketogenic diet tends to work in those who have resistant epilepsy to like medications and other treatment options. So oftentimes ketogenic will be tried after a number of things have failed. But it's hard to maintain. It's also hard to prolong it because of its impact with that high fat. It can start to have some impacts on liver, on cholesterol, those kinds of things. So it's carefully monitored. And then we do know also that there's medical cannabis, and medical cannabis is, we know that epilepsy qualifies as a condition for receiving medical cannabis through the certification process in Minnesota, which you can see here. But I also just want to mention that there is one FDA approved medication that has medical cannabis as its derivative. It's called Epidiolex, and it's only approved for 3 childhood epilepsy syndromes that are rare, those being Dravet, Lennox-Gastaut, and tuberous sclerosis. And so if you have more questions on this one as well, we can provide more information to you if you are interested in that. We also know that there are some additional impacts of epilepsy. Obviously, there's the physical and emotional health. We know that there is impact socially on the family as a whole, on the individual themselves. We know that there's a lot of cost associated with a chronic health condition. And for children, there can be some learning difficulties or delays or accommodations needed as well to allow them to learn at their own pace, things like that. And one of the biggest things that we hear from individuals and families is the isolation, and they feel like nobody understands. And so one of the things we work at is connecting families to each other so that there's less of an isolated feeling, or connecting adults to each other. So the additional impacts are at times just as severe as the actual seizures themselves. We do have a few resources that I've mentioned throughout. If you go to efmn.org, you'll see one of our drop-down menus has what's called a resource library, and there's a plethora of templates and brochures that you can download, including a seizure action plan and a seizure observation record. I highly recommend that you go to our website and look at those, because they give you, you could print those and use as you would like, but they give you ways to quickly record what you are observing, or to, you can hand a seizure action plan template to a parent and say, hey, we know that this is used by many people with epilepsy or children with epilepsy. If you could fill this out, have your doctor fill their part out and bring it back, that will provide you as the childcare providers with the individualized plan of care that you will know individually what that child needs as far as their seizures. And you'll also be able to tell what they're taking for medications and what their seizures typically look like and how long they last, as well as emergency protocols. Like I have mentioned throughout, we do have information services. One of the key programs that we really are proud of is that we're able to provide customized one-to-one support to anyone who is requesting information about epilepsy and seizures. You might have epilepsy yourself, or you might be working with someone who has epilepsy, or be that teacher or that provider. And so the link to our webpage is here, but if you go to efmn.org and click through, you'll see information services under one of our drop-down menus, and really you can fill out that web form, and we really do provide that customized one-on-one support. We reach out to you, answer your questions, ask questions to make sure we give you what you need, and then get those resources for you and send them on to you. We also do provide referral services. If it's a situation where we don't provide that specific service, we work with other social service agencies to make sure that things like housing and food support, like we have those referral agencies that we utilize as well. Finally, this is our mission statement. We lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. There is an evaluation at this link if you are interested in helping us out by providing feedback. We are a nonprofit, so if you are impacted by seizures, or you really feel strongly that you would like to give back, there is our Give a Gift website, and then my contact information is there. Again, if you have questions, you can reach out to me via email or phone. You can also reach out via the website by filling out our information services web form. We will get back to you as soon as we can, getting those answers to you for those questions. And I just want to say thank you for joining us for this training. And I hope you've learned a lot, and that if you have questions, you can just reach out.